Occlusal vertical dimension. Occlusal vertical dimension is the vertical position of mandible in relation to maxilla when upper and lower teeth are intercuspated at the most closed position. T occurs when the teeth are fully intercuspated. However, teeth are not the determinant of occlusal vertical dimension. It's actually the teeth are positioned within the space between the fixed maxilla and muscle-positioned mandible. The mandible goes repetitiously to the position dictated by the contracted elevated muscle. Vertical determinants. There are 4 philosophies for condyle position when determining vertical dimension. First is gnathological. Fully adjustable articulator is used to determine condyle path for a 5-degree increase to ensure no posterior interference. For bioaesthetics, it involves on-fixed values based on incisal relationship. Distance between gingival margins of 18 to 20 mm in an unworn class 1 incisal with an upper incisal length of 12 mm. The lower incisal length is 10 mm, 4 mm over bite and 1 mm over jet. Third is centric relation based, which follows the principles of P. Dawson, whereby centric relation is defined as when the head of condyles are in the most superior position within their sockets, lateral tragoid muscles are contracted with the disc properly aligned. For neuromuscular, it is based on principles of muscle activity determined by electromyography. There are a few rationale to alter occlusal vertical dimension. First, is to improve aesthetics by altering facial form and/or tooth and gingival display. Next is to improve occlusal relationships such as correcting anterior open bite. And last is to gain space for the restorations. When changing incisal position restoratively, it is important to follow all the guidelines and provide them in form of provisional restorations. Ensure stable occlusal contact by providing a definite palatal contour. The upper half of the labial surface is continuous with the labial surface of the alveolar process. The lower half is in two-plane for incisal position and allow the lip closure path to slide along the labial surface. The incisal edge position should rest along the inner vermilion border of lower lip. Clinically, it can be determined by asking patient to count from 50 to 55. Anterior guidance is determined by the protrusive path but should also include a long centric. The contours be no interferences with the T, D or S sounds. Finally, it important to check for freemeters to exclude premature contact. Dento-alveolar compensation. The developing occlusion responds to discrepancies in the skeletal dental base by changing the axial inclination of teeth and alteration of supporting bone. This compensation mechanism assists the establishment of occlusion. Often, dento-alveolar compensation occurs in patients with tooth wear without any loss of vertical dimension. Occlusal plane.
Occlusal plane refers to an imaginary surface that theoretically touches the incisal edges of the incisors and tips of the occluding surfaces of the posterior teeth. It is, however, not a flat surface. The plane is acceptable if it permits anterior guidance without any interference.
For anteriors, the curvatures are determined by the establishment of correct smile line for the upper and the relationship of the lower incisal edges to the anterior guidance and phonetics requirement. For posterior, the curvatures for the posterior occlusal plane are divided into two. the anteroposterior curve which is the curve of Spee, and the mediolateral curve which is the curve of Wilson. Curve of Spee is the anteroposterior curvature of occlusal surface. It begins at the tip of lower canine further to the buccal cusp tips of bicuspids and molars up to anterior border of the ramus of mandible. It would ideally follow an arc through the condyle, and the curvature of this arc relates on average with a 4-inch radius. What is the significance of curve of Spee? The anteroposterior curvature of the occlusal plane is designed to permit protrusive disclusion of posterior teeth by combination of anterior guidance and condylar guidance. This makes the shearing action of incisors possible and more efficient incisive function. Occlusal plane also protects anterior teeth from being overloaded. The elevator muscles' activity are shut off during complete posterior disclusion. However, if there is any interference posterior to the canines during excursion, the elevator muscles are triggered into hypercontraction. Thus, it is important to have a correct occlusal plane, as there are possibility to damage the teeth, joints and periodontal structures. Curve of Spee is a mediolateral curve that contacts the buccal and lingual cusp tips on each side of the arch. It forms a curve due to inward inclination of the lower posterior teeth, and the lingual cusps of mandibular posteriors are lower than the buccal cusps. For the maxillary arch, the buccal cusps are higher than the palatal cusps because of the outward inclination of the upper posteriors. Why incline the posterior teeth? First, aligning both upper and posterior teeth with the direction of internal tragoid muscles produces greatest resistance to masticatory forces, thus reducing functional stress. Secondly, the inward inclination of lower the occlusal table allows direct access for the tongue to get food the occlusal table from lingual. Alternatively, the bands of buccinator will toss food on the occlusal table with the outward inclination of upper occlusal table. The upper palatal cusp serve as baffle for food tossed from buccal as well as the lower buccal cusp.